Thank you, sir. Good afternoon, ladies and gentlemen. Today my topic is counseling patients for presbyopia correcting IOLs, our very well-known multifocals and trifocals. So we know achieving spectacle independence is challenging. One would expect that with the combination of advanced diagnostics, the new technology of IOLs, the better IOL calculating formulae and the advanced surgery, one would result in a very happy patient. But sometimes that isn't so. Today we will talk about counseling patients who have been selected. And how do we select such patients? So basically these are patients who have been examined and are anatomically suitable. There are also, these also include a subset which are the patients in the gray zone due to their inherent anatomic variations. For example, they may have a large pupil size, a large angle kappa, or they may have significant astigmatism. Then, of course, there are patients who are not suitable for the multifocal IOL implantation. There are many more to this list, but I have enumerated some of the glaring ones. So these are the patients who are an absolute no-no, and if you want a peace of your mind, then don't implant a multifocal IOL in them. They should be offered an option of a monofocal implantation. So now let's look at the patients who can be a potentially happy one. There are certain characteristics which should be looked at before determining, and this list will help you. A detailed discussion about his temperament is, you can judge him yourself. Is he a perfectionist? Does he come across as a type A person? A detailed discussion about the lifestyle choices and the needs should be done. Get to know his profession. Does it entail a lot of near work, computer work, or maybe field work? What are his hobbies? Does he drive at night? It is very important to judge the visual expectations of the patient, and if unrealistic, it is better to clarify it right then and there. The anatomical aspects of the eye which needs to be looked at before implanting the lens are angle kappa. As we said, if it is large, it has a tendency to cause a reduction in the contrast sensitivity post-surgery. This should be explained. A large pupil size, it will cause increase in the symptoms of halos and glare post-operatively and a reduced vision. And of course, a significant astigmatism should be noted, whether it can be corrected by a multifocal IOL or not. Another key issue to address is, of course, the lifestyle needs. This should be looked at in detail. Talk to him about his vision-related day-to-day activities. You can also ask him, is he comfortable wearing glasses? How much reading does he do in the day? So all of these will give you a fair idea how he would cope post-surgery. Very important to see is the vision expectation. Let me explain this by giving two examples. We had a 24-year-old myopic patient who came to us with a posterior polar cataract and a best corrected visual acuity of 6/6. Now his primary complaint was that he didn't wish to wear glasses or contact lenses while playing. He was a professional player. He also gave a complaint of having glare while playing in the night because of the floodlights that were on the stadium. So now he wishes to get rid of his glasses. So we are presented with three options here. One, if we want to take into consideration the PPC and we think about taking off his cataract, we can implant a multifocal IOL in him, which will give him a decent vision for distance and near, both during day and night. But the complaint of glare, which is significant for him, will still be there after a multifocal IOL, so maybe this may not be the best bet. The second would be to implant a monofocal IOL in this patient. He will get excellent vision for distance during the day. He will play very well, but of course he will have to wear glasses for near. So the third option in this patient would be a corneal refractive surgery, maybe a LASIK or SMILE, which will give him a good distance vision. The glare which he still has, but probably he's used to it, will remain, and it will maintain his natural lens in the eye. So for this patient, a multifocal IOL implant would not be the first choice. Versus a 62-year-old hyperopic patient who came to us with early cataract. We will look at his personality a bit. He is irregular with his spectacle wear. He wears it on and off. He is not keen on wearing glasses, because of which he has come to us for second opinion. He wants to get rid of his glasses also along with the cataract surgery. The best thing that we noted is that when he came to us, his prescription had changed pretty significantly, but he didn't seem to notice that. So for us, this is an ideal patient to operate on. Hence, it is important to discuss the patient's expectations preoperatively, and the reality of different needs to be addressed right then and there. Now, we know that we should explain these expectations and realities. These points you can cover with the patient. Most IOLs give a good distance vision. Intermediate and near may vary, but gets better with time. The vision can fluctuate in the early post-operative period, but it does stabilize over a month or so. Vision may vary in dim illumination, And it is always better when the IOL is implanted binocularly. And eventually, if all of these problems occur, then neural adaptation takes over, and this will reduce eventually. So it is typically what would be your ideal patient? A hyperopic guy with a happy temperament who enjoys watching television, likes his outdoor activities, reads occasionally, should be preferred. And then the icing on the cake would be that he or she hasn't noticed the change in their spectacle prescription, as it really hasn't bothered them. So this is your ideal patient. So if this near perfect guy doesn't come to your clinic, it is better to clear a couple of things beforehand. You must explain to him the advantages and weaknesses of the lens, if the case permits. Then it is always better to undersell and over-deliver in such cases. An open dialogue definitely helps between the patient and the doctor. So the advantages of the lens is that it gives a spectacle dependence reduces. The pitfalls such as the glares, halos, rings around the light, reduced contrast in dark illumination should be informed if appropriate to the case. Now it shows that the patient, if all of these explanations don't make the patient understand what he really is going to go for, this IOL counselor tool is an excellent patient education software which can be downloaded online. You have to pay for it, of course, but it can show a preview of how the patient is when he has presbyopia, when he is normal, how he looks when he has cataract, and how he would look after a standard monofocal IOL implantation. His distance gets corrected, not his near, and how after a multifocal IOL implantation where both distance and near can be shown clearly. Now this is about a man driving. Similar examples of a man playing or a patient doing his other day-to-day activities are also there on this website. Now essentially your counseling skills are going to be put to test by 3 types of patients. These are first 2 who are suitable for the multifocal IOL implant, but the first is unable to understand the pros and cons of the lens correctly even after you have explained, and second is having a financial problem, of course. Now both, if counseled properly and maybe with a little help from you towards the financial side, can be converted into potentially happy patient. Excuse me. This is the third type of patient who understands the benefits and the possible disadvantages of the lens, but he or she is very happy with the glasses. I don't think you should push too hard for multifocal in these patients. Let them go. So to summarize, the best way to avoid drama is a good patient selection, as we have seen. It is more an art than science, and most times the experience and the surgeon's judgment works best. So the counseling should definitely touch on the points of possible optical aberrations, the neuroadaptation, the enhancement, and a talk on resurgery should be mentioned beforehand, with either a piggyback or a corneal refractive surgery, as the case may be. This can reduce a lot of aggravation post-operatively, should be spoken before. Enhancements should be spoken, as we just said. Inherent risks of the surgery and an IOL exchange in case can be told to the patient. In the end, I would say be confident in your decision, and if you know that the lens works well in your hand, go for it. Undecidedness equals poor conversion rates, so be confident. And spending more time preoperatively definitely will lead to a lesser time spent with the patient post-operatively. Thank you very much.